Hi, good morning, and thank you to the chairs for the invitation. We'll go on to my mandatory disclosures. So we're all in the room familiar with PEG placement. It is a versatile procedure, but it doesn't really fit all patient needs and scenarios. So I'm going to talk about a variety of enteral feeding access options, from things that are a little bit more routine to things that are a little bit rare in terms of indication. All of these, except for the last two, are endoscopic dependent, and the last two are endoscopic adjacent, which can be done in a variety of different formats. So just a little bit of a landscape, sort of the menu of enteral feeding access. If you think about it a little bit in terms of where your avenue is it a percutaneous access, is it a natural orifice access, and where your target anatomy is, you can sort of categorize this in terms of how you would go about planning for a procedure. And I think that's really sort of the bottom line of this talk is appropriate planning for the intervention and the patient-specific criteria to choose the appropriate procedure. So procedural planning elements, number one, any cross-sectional imaging that is available, you should review. If there's any concern over patient anatomy, certainly obtain pre-op imaging. Fluoroscopy intra-procedure is extremely useful. Make sure that you are on a bed that will accommodate it and it's appropriately positioned. Other adjuncts that could be useful as well is the use of ultrasound as well as multiple endoscope options in order to traverse challenging anatomical settings. So specific concerns may be obstructions of the oropharynx, nasal obstruction, cancer of the head and neck that may raise concern for seating of the tract, and absence of a appropriate radiographic window for percutaneous access. One of the ways that sometimes we're able to circumvent this is I employ my IR colleagues to just get a small caliber drain into my target anatomy, and I can certainly get a more appropriate feeding tube in by upsizing that under endoscopic guidance if need be. So Dr. Wong did touch on some of the options in terms of endoscopes and how they have different lengths, different diameters. Additional tools would be the T-anchors, which Dr. Rendell mentioned as well, through the scope clips, which we've spoken about, guide wires for the guided exchange that I mentioned earlier. And sometimes when there really is a narrow window due to the transverse colon position, you can do concurrent lower endoscopy at the time of your feeding access to try and manipulate the colon out of the way and expand that window for percutaneous access. So just to highlight here, this is a 1T spec sheet, which mentions the 3.7 millimeter working channel, and that accommodates an 11 French through the scope feeding tube if need be. We'll talk a little bit more about that momentarily. So this procedure specifically we're going to talk about is tubes placed nasally and orally, percutaneous puncture, multiple methods in terms of PEG, which most people are familiar with, but we'll review. PEG with a J extension, percutaneous endoscopic jejunostomies with direct puncture. And then the last two are going to be esophageal puncture for gastric access and pharyngeal access. So traditional PEG, you'll need a gastroscope. The kits usually come with the majority of the supplies that you would need to proceed with the procedure, with the exception of perhaps T-anchors. Most of them do not contain that. They come in a couple of formats. We'll review a couple of those momentarily. Contraindications, times you may not want to do this, is if patients are unstable, they have large volume ascites, varices of the stomach, active bleeding, anticoagulation. It's a high-risk procedure from a hemorrhage standpoint. Patients with carcinomatosis, active skin and soft tissue infections, and patients with evidence of peritonitis or ongoing sepsis. So I'm going to just quickly go past the steps. We'll review this sort of in the process of the videos that follow. So the T-anchors that have been mentioned before, they really allow you the ability to pexy the tissue in place percutaneously. It's basically a hollow bore needle with a pusher. And when you deploy the pusher, there's a suture at the end of this, and that's attached to this metal crossbar. So much like if you go shopping and you see the tags on your clothing with that little plastic T-bar, it's the same thing essentially, but for GI tract pexy. So it's useful in malnutrition, poor healing, ascites, patients who are getting non-invasive ventilation to avoid any early egress of gas into the peritoneal cavity. Patients were disoriented, were worried about early tube dislodgement, and in some of the advanced procedures, particularly the use of the introducer and in PEG procedures, as we talk about here. Just schematically, a PEG tube with this demonstrates a pull method where the scope is being followed, following the tube, and the tube is being withdrawn through the abdominal cavity. So the kits that exist are basically two flavors. It's push and pull kits. The pull kit is a looped guide wire and a much shorter dilator, whereas the push variety has a much longer taper. And for people who maybe use only one particular kit at their institution, I will indicate which is which. So this demonstrates the push method dilator. You can see this entire region here is one long dilator. There's a straight guide wire that's introduced through your percutaneous gastric access, retrieved through the mouth, and this entire dilator is sort of like a swallow the sword, dilated all the way down through the esophagus, and you still are holding on to this portion here by the time the dilator emerges through the abdominal wall. This is just same schematic. Whereas the pull is the looped guide wire, where you would withdraw the looped wire after attaching the tube to the end. And that tube is attach the wire through the tube, around the tube, square knot, and then withdraw. So just a video. This is our safe track. You can see a needle puncture here, simultaneous visualization of the needle entry into the stomach as we have aspiration of gas extracorporeally. We're getting ready with our snare to capture our puncture needle and sheath. And always be attentive to where the end of that needle is, and you don't want to lose it off screen because you could end up with a posterior gastric wall puncture and a delayed hemorrhage. The guide wire is going to be introduced. It'll be snared. It'll be withdrawn through the mouth. The tube will be attached. This is the looped guide wire, so this is a pull method that's being demonstrated here. Tube is being snared. It's being followed down into the stomach. It's released in the esophagus. The scope is advanced. Tube position is confirmed. Always advance the tube a little bit to make sure that there's no hemorrhage adjacent to the puncture site, and that can be managed prior to leaving the operating room. Sorry about that. Let's try that again. So the introducer method, it involves a peel-away sheath and dilator system. This can be a one-piece system that's purchased commercially, or this could also be done using sort of vascular access sheets if need be. Reasons why we would do this: unable to pass an adult scope into the stomach. If you have a patient with head and neck cancer or esophageal cancer and a very narrow esophageal lumen, you may not be able to pass the standard bumper from a traditional PEG transorally. And if you have concerns over potential seeding. So you need a small caliber scope. Same elements of your kit in terms of fasteners or the new addition. Everything else should really be in your traditional kit. It's the Seldinger method. I misspelled that. You're going to use a puncture needle, guide wire, or a stepped introducer, and then you can use your gastrostomy tube. Traditionally, you can use a balloon tube off the shelf is the easiest. There are some other deployable tubes that are available commercially as well. So the introducer kits contain everything that you need, including the introducer, guide wire, puncture needle, and they also involve a stoma measuring device so that you know the exact length in case you wanted to go to a low-profile system immediately. So we can watch this. There's going to be placement of the T-anchors, as we talked about. That's what they looked like intraluminally as you deploy them. You generally place 3 of them to provide stabilization and try to puncture towards the center of that triangle. Going to be a guide wire introduced here. And then over the guide wire, you're going to see the stepped dilator. And then that will be removed, and the peel-away sheath will be left in place. The one thing to be aware of is the moment you remove your dilators and you're left with the sheath, you're going to lose your insufflation and your view is going to collapse. So just be aware of that. The other benefit of having those T-anchors in place is you can place them on traction and you can artificially elevate the anterior gastric wall and create a little bit of space for visualization. You're going to see the tube starting to enter here, and then we'll pull it out, and I think I have a single shot of the tube in position. Okay. There are some other commercial options that exist, which include a trocar-based introducer with a peel-away sheet. This can also be done with a traditional trocar and a tube system that is deployed through there. There's a commercial gel cap system that exists that can be used in that format. The PEG-Js, generally colonoscope is useful for the additional length to make sure you have distal feeding access, and you are able to place a T-anchor to secure that. You can also place an extension through an existing PEG without replacing the whole system, so I'll demonstrate those here. Ways to think about this is if you have a prior tract, well-established, you can replace that with a single-piece GJ system. If new, you can place an extension or place anchors and replace a single-piece system as well. This is the conversion kit where you place this through the PEG itself. The external portion is threaded through, and this is the distal portion that goes either post-pyloric or jejunal. Suture loops that you can grab those and drag them with your through-the-scope clip. This is through-the-scope clips as we've covered already. This is a single-piece system, also with a suture loop so that you can advance it distal. Patients who already have a G-tube tract, another option is to do a ultra-slim scope through the actual gastrostomy tube, navigate to the jejunum, place a guide wire, and then advance your jejunal feeding tube over the wire. So this demonstrates a single-piece GJ. I had a clip misfire, that's why there's already one on there. We're going to advance this tube into the jejunum. Once we go post-pyloric, we'll navigate the duodenum. We'll find a fold of mucosa. Always cross-check that you're not occluding your lumen and grabbing both walls when you deploy your final clip. I always wait to deploy that clip until I've pushed the clip forward and pulled the scope back. In that way, that acts as a pusher and maintains the position of that distal tip of the tube as I withdraw into the gastric lumen, so that as you back your scope back, you are not going to accidentally dislodge the distal position of your tube. You can confirm this during the procedure with fluoroscopy to ensure that you don't have any disruption of your position. I'm going to just forwards for the sake of time. For PEG, patients with prior foregut anatomy, foregut surgery, altered anatomy bypasses, patients with Bell-Roths, patients post-Whipple, you would be concerned about the ability to do a traditional PEG and access your remnant stomach from your Bell-Roths or Whipples. Use your fluoroscopy liberally and maintain visualization of both endoscopic and fluoroscopic views throughout the procedure. Your supplies can be identical. You can use a standard PEG kit for a PEG. You are going to use the T-fasteners as well. This is a patient who had a Whipple and had some issues with malnutrition and PO tolerance. This is an existing nasojejunal feeding tube going through the efferent limb of a loop GJ. T-anchors are being placed here. And then this is going to be a direct puncture, and we're going to place a standard PEG kit through the jejunal wall. I do get a little bit tangled on that T-anchor, so you'll see me fumble with that for a moment. The reason for this patient where it wasn't just a straight jejunostomy tube being placed through this, it was that she had medications that she was on, that my concerns were that if I placed a straight J tube through there, that she'd occlude. So we placed a extension through that. So this is the jejunal feeding extension through a PEG, although not in a gastric position. This is placed in the efferent limb of a loop GJ. So other options for maybe less durable access and natural orifice, so nasojejunal access. You can go transnasal in awake patients. Usually tend to use a nasal trumpet to protect some of the turbinates and the posterior nasopharynx. And you place this over a guide wire using an ultra-slim scope. Patients who are intubated or sedated, you can go transoral. You will need to eventually pass that tube either through the nose at the start of the case and then drag it down, or pass it in a retrograde fashion. So these can be standard core flow or Keo feeding tubes with a distal loop that you attach with a suture, or there's through the scope formats that fit in an 8 French and a 10 French, depending on whether you're using a diagnostic or a therapeutic scope. All of them I do recommend grabbing with a through the scope clip to confirm and place it distally. This can also be done with a grasper, but my preference is to place a clip. Use your fluoroscopy liberally during this as well. This is a patient who had a GJ leak after a gastric bypass. Once the sponge was confirmed in position, I just navigated beyond that, placed a guide wire, and this is a through the scope NJ feeding tube that you're going to see deployed here momentarily. You're going to see a guide wire emerge, followed by the portion of the feeding tube, and then you're going to see the scope back out. There are a couple of fluoroscopic still images at the tail end of this video. There's your guide wire being deployed, feeding tube. Scope is going to be backed out. And you'll see here the tip of the scope. You'll notice a guide wire followed by the tube, guide wire and tube, backing the scope out as we go. There are a couple of other drains, and then there's an evac there visible on the screen. Like I mentioned, I do use nasal trumpets to protect the posterior nasopharynx during transnasal endoscopy. And then just lastly, to whet your appetite, this can be done under endoscopic guidance. Patients who may have other contraindications, you can do pharyngostomy tubes through your thyrohyoid ligament under laryngoscopic or even flexible endoscopic view. There's also balloon puncture transesophageal gastrostomy that can be done by parking a scope in the proximal esophagus and puncturing a CRE balloon, or when radiology performs these, they'd use a special balloon for that purpose, also with ultrasound guidance. This demonstrates esophageal puncture and a distal feeding tube being passed into the stomach with a contrast opacification for verification. So there's a large variety of options for enteral feeding access. Know what your options are, identify your target, identify the barriers that are in your way, obtain and review your imaging, choose the safest option to get to your target, and use liberally intraop fluoroscopy to help guide your choices. Thank you.